Mr. Chairman, dear colleagues, thanks for the kind invitation وcongratulations لأخويا دكتور حسام وكل البورد بتاع المؤتمر على المؤتمر الرائع ده. الكيس بعنوان CTO PCI struggle outside the cath lab. Patient كان 67 years old gentleman, he's diabetic, hypertensive, underwent primary PCI للRCA 2 months قبل الايفنت ده وكبت وقتها على دابت تاكاجريلور واسبرين. والكورونال انجيو في الوقت ده بينت ان في CTO at the mid LED planned for staged PCI later on. البيشنت lost follow up كده 2 months then appeared again complaining من angina class 3. ال ECG كان فيه ST changes في V3 to V6, echo showing abnormal LV dimensions, mildly impaired contractility, hypokinesia at the LED territory. This is a coronary angiogram, patent RCA stent. This is a dual injection to guide the CTO PCI. Patient underwent successful PCI لل CTO LED without going للديتيلز بتاعت ال PCI. And I was run before PCI to guide the landing لأن كان في disease extending to the ostium of the LED, so IVAS was mandatory to guide the landing zone, either to do a left main stenting crossing over the LCX or land at the ostium. والحقيقة الIVAS باين إنه disease is confined to the LED, left main is not affected, so I landed the stent at the ostium with this final result, 2 overlapping stents. This is post PCI IVAS run showing well deployed, well opposed stents. 1 hour later, the patient اشتكى من chest pain ب ST elevation V1 to V2 and developed first degree heart block. So I decided to go to the cath lab again to get a rapid shot. كان باين إن first septal branch is pinched, lost flow. So wiring to the septal branch, just balloon dilatation, and it was a big septal branch where chest pain off the patient went to the CCU والدنيا تمام. وأنا مشيت في اليوم ده where I decided to put the patient على 1 bottle of tyrofibane لأنه كان في haziness at the septal branch ostium. 7 hours later, the on-call cardiologist called me. The patient developed some petechiae at the abdomen. Then 1 hour later, there is ecchymotic patches appeared on the chest wall. So again, we went radial and femoral. So he had bleeding with swelling and ecchymosis at the forehand. So what to do? Of course, immediately we stopped the tyrofibane. Urgent CBC showed that platelet count was only 2. His baseline platelet count was 185. So what is the differential diagnosis for such aggressive thrombocytopenia? This patient underwent PCI 2 months before this admission, and he received heparin. Again, he received heparin again on this PCI. So for me, I should put HIT, or what's called heparin-induced thrombocytopenia, as differential diagnosis. Let's rapidly review what is heparin-induced thrombocytopenia. It's an immune-mediated adverse drug reaction, where there is a drop in the platelet count more than 50%, and it occurs in approximately 1 for every 5,000 hospitalized patients. It has a very complex pathogenesis. First, the activated platelets releases the platelet factor 4, which binds للpolyanions اللي على الهيبرين. And this is the same mechanism by which thrombocytopenia occurs in patients with septicemia, where platelet factor 4 binds to the polyanions at the bacteria. And in 2 scenarios, immune complexes are formed. Beta lymphocytes generate anti-platelet factor 4 polyanion IgG, and immunocomplexes are formed. ال FC part على ال IgG binds to the platelet FCY receptor, resulting in again, strong platelet activation and platelet aggregation. This results in platelet consumption and production of platelet-derived microparticles that accelerate the thrombin generation. HIT antibodies activate monocytes, endothelial cells, inducing additional tissue factor expression and increase in thrombin generation, leading to an increased risk of thrombosis among patients with HIT. بتحصل امتى الهيت دي؟ typically occurs 5 to 10 days after the heparin is started. Heparin exposure within the previous 90 days, specifically in less than or equal to 30 days, there may be persistent circulating antiplatelet factor 4 antibody, heparin antibodies, and HIT can occur in such patients in a more rapid form. كل ده بيؤدي إلى counterintuitive action. So I give the heparin as an anticoagulation, and what happens in some patients is thrombosis. So thromboembolic complications develop in around 50% of patients with HIT. Lower limb venous thrombosis, pulmonary embolism are the most frequent complications. Peripheral arterial thrombosis, then stroke comes afterwards, and myocardial infarction is very rare. There is other type of HIT which is called the non-immune HIT, which occurs most frequently, and it's characterized by a mild decrease in the platelet count. والtype ده زمان كنا بنسميه ان هو type 1 HIT. Nowadays there is no type 1 HIT, there is heparin associated thrombocytopenia for the type 1, formerly called type 1, or the HIT, and when we say HIT we mean the immunomediated type. So back to our patients. Diagnosis of HIT relies on these 4 stations. First, the platelet count, clinical thrombotic events, platelet factor 4 antibody assay, and the 4T score. 4T score بيبقى فيه 4 parameters, each parameter بياخد grade 0, 1, or 2, and you calculate the final score of the patient. If you get 6 to 8, there is a high score, the high probability of HIT. 4 to 5, there is an intermediate probability, and 3 to lower, there is a very low probability of HIT. So back to the patient, platelet count is 2, so there is a confirmed thrombocytopenia, and his 4T score was 5, so we have an intermediate probability of HIT. So what is the treatment? Treatment, number 1, discontinue heparin. Never ever give even flushes with heparin, can reactivate the circle again. So discontinue heparin. Number 2, avoid platelet transfusion, because this can be as you are adding fuel to the fire. In some patients with thrombotic events, you will need an anticoagulation at a therapeutic doses, because there is a massive thrombin generation in such patients, even if the patient has no apparent thrombosis. And vitamin K antagonists shouldn't be given until platelet count has increased to more than 150,000. Because, as we know, there is increased risk of venous limb gangrene and limb loss by decreasing the level of protein C after initiation of warfarin. طيب بنعمل anticoagulation بإيه؟ بدايركت thrombin inhibitor by bilirubin, or we can replace this by the fondaparinux instead of direct thrombin inhibitor. So having this in mind, what can I do? So what I did in such patient, I stopped the tirofiban. We did a literature review. في الحالات اللي زي دي أحيانا الديسيجن محتاج يبقى shared, and you need to consult your colleagues, your senior colleagues. So I called 2 of my senior professors, and we discussed the case together. There is some case reports على patients on initiation of glycoprotein 2B3 antagonist, they developed severe and significant thrombocytopenia. And the mechanism is just postulation. There is no confirmed mechanism around immune-mediated ones. So should we do platelet transfusion for the patient? Give direct thrombin inhibitor? Or should we stop DAPT for this patient? Patient has both increased risk of thrombosis and bleeding. Patient had 2 PCI, one of them had the acute coronary syndrome 2 months before this one, and 2 different territories, RCA and LAD. So what we did that we did a duplex for the patient, and it was duplex free. There is no thrombotic events. So we decided to wait for the direct thrombin inhibitor. We did a platelet factor 4 immunoassay. However, this was going to take 2 days to be confirmed. I decided to hold the DAPT for only 24 hours and do a regular follow-up for the platelet count. After 12 hours, platelet rises to 12,000. Next day, it rises to 17. So I de-escalated the antiplatelet therapy from ticagrelor to clopidogrel, and I decided to load the clopidogrel at a lower dose than recommended because there is a very low platelet count. On next day, platelet rises to 21, so we resumed the aspirin, kept the patient on DAPT, and platelet factor 4 antibody assay came negative after 2 days, so this was not a hit, it was 2B3A associated thrombocytopenia. Patient was discharged home after 5 days with platelet count at 100,000. My take-home message is that heparin is widely used in PCI, ACS patients, venous thromboembolism, AF, end-stage renal disease, hemodialysis, and everyone should be aware about HIT, and this could be a life-saving for the patient. Glycoprotein 2B3A antagonist can induce serious thrombocytopenia. Calculation of the 4T score helps in HIT diagnosis and management. And putting coronary stent in some patients could be the easy part in some scenarios. And my last point is medical management is always a matter of balance, and documentation and prevention of subsequent incidents should come at our first priority. So patients diagnosed with HIT in any other part in the world, they receive card like this, that I was diagnosed with HIT, so please avoid using heparin again with me. So I decided to document this in the PCI report that this patient developed serious thrombocytopenia on initiation of 2B3 antagonist, which was not fully justified in my case. So please avoid using this in subsequent intervention unless highly indicated. Thank you very much.